We're going to talk about chapter 53 now, which is the fetal growth assessment by sonography. Now, when we measure the baby, which we talked about in chapter 52 of your measurements, you're going to get the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. There's multiple reasons we measure the baby just to see how the baby is growing. But let's say something's abnormal with those. The baby's too small. And that's called intrauterine growth restriction. And IUGR best described as the decreased rate of fetal growth, and it complicates 3 to 7% of pregnancies. It's commonly defined as fetal weight at or below the 10th percentile for given gestational age. So make sure that you remember that less than 10th percentile is considered IUGR. There's maternal factors why a baby would not be growing. It seems like some moms just struggle to grow big babies. If they have a previous history of fetus with IUGR, they have a higher chance of having another baby that has this issue. If a mom is very hypertensive, it can cause IUGR. Any kind of cigarette use, tobacco use. If there's a uterine anomaly present, if there's a placental hemorrhage, which we talked about in the first trimester chapters, or if the placenta is just not working, it's insufficient, which I feel like that's probably the most common that we see, that or the maternal hypertension. Now, this is a huge thing. Do not confuse IUGR with the term small for gestational age. Small for gestational age describes the fetus with a weight below the 10th percentile without reference to cause. We don't know why that baby is small. Fetal growth restriction describes as a subset of SGA with a weight below 10th percentile as a pathological process. Like we know that this mom has a subchorionic hemorrhage that is causing this baby to be small. So if we don't know, it's SGA. If we do know what's causing it, it's IUGR. The classification of the IUGR is based on the morphological characteristics of the fetus studied. There's two types that we really look at. It's symmetric and asymmetric. Now, symmetric IUGR usually occurs in the first trimester. And it's from like a chromosomal abnormality like triploidy, part of a molar pregnancy, which we learned about a little bit ago, or an infection like parvovirus or toxoplasmosis, one of those infections that can cause growth restriction. And what's going to happen is the baby is just going to be proportionally small throughout the whole pregnancy. So the head, the belly, and the femur are just going to be small. And this occurs in about 20 to 30% of all IUGR cases. Also, the timing of the pathological insult is recognized as more important than the actual nature. So if it occurs pretty early, it's worse. Asymmetric IUGR is what we usually see, and it begins late in the second or third trimester, usually results from placental insufficiency. I feel like that's the main cause of IUGR. The fetus usually shows head sparing at the expense of the abdominal and soft tissue group. Now, the body is so smart. The fetus wants to shunt that blood, as much blood as it can, to the brain, because it knows somewhere in its body, it knows that the brain needs the blood to function. So it spares the head while the abdominal circumference gets very, very small, because the liver is very sensitive to any kind of growth restriction. So the fetal length, it kind of depends. It exhibits varying degrees of compromise, but it usually is still also compromised throughout this. Early diagnosis of IUGR and close fetal monitoring, such as biophysical profiles, Doppler, and fetal growth evaluation, of significant help in managing pregnancy suspected of IUGR. Now, when a patient is IUGR, sometimes they are sent to a maternal fetal medicine doctor, a perinatologist, and that's who I work for. I'm one of the sonographers now for them. PRN because I do this, but I we monitor these babies and these moms that have these issues a lot closer than in a normal population of people. We do a lot of biophysicals and Dopplers on them. So clinical observations and actions for IUGR. So the clinical signs are decreased fundal height and fetal motion, baby's not moving around as much. And these are the key sonographic markers: the grade 3 placenta before 36 weeks, or decreased placental thickness, and then the baby measuring small, of course. So if this happens and we see this, we want to call the doctor and let them know that the baby is measuring small. So, and we'll also carefully evaluate the placenta and the fetal anatomy, and we'll ask if they want us to do an umbilical artery Doppler just to see if there's increased resistance to flow. So when I say grade 3 placenta, this is what I mean. So this is on the right is a beautiful, smooth grade 1 placenta. There's no calcifications, there's no lobulations, it's just a smooth hypoechoic mass. Over here on the left side, you can see there's lobulations, calcifications. It just looks ugly, right? And this is considered a grade 3 placenta. That placenta is about to just poop out. So the multiple parameters for the IUGR, the BPD is imaged in the transverse plane. The BPD can be misleading in cases associated with unusual head shapes like dolichocephaly, brachiocephaly. So alone, it's a poor indicator of IUGR. You have to have everything together. The head circumference to abdominal circumference ratio is a high false positive. So that's not really good. A femur length to AC ratio is not dependent on knowing gestational age. So really what they're trying to say is that you just need to measure the head, the belly, and the femur. And usually that will give you your best accuracy of knowing if the baby is growing accurately or not. So the most reliable estimated fetal weight formulas incorporate several fetal parameters such as the biparietal diameter, head circumference, abdominal circumference, and femur length. It's important because overall reduction in size and mass of parameters naturally gives below normal EFW. And an estimated fetal weight below the 10th percentile is considered by most to be IUGR. Another thing to remember with IUGR is they will get oligohydramnios, which is less than 5 centimeters of amniotic fluid index fluid, because the urine output might be reduced. Polyhydramnios develops if the fetus is having trouble swallowing, and that's greater than 24 centimeters. If we're cutting the mom's belly in 4 quadrants and doing the amniotic fluid index, and we look at one pocket, and if it's less than 1 to 2 centimeters, it may represent oligohydramnios or IUGR. However, a patient can have oligohydramnios for other reasons than associated with than just IUGR. There's other reasons why a mom could not have enough fluids, so that's why it's important to just consider that. However, it could be associated with IUGR. So on the left, you can see here, this is placenta, the baby, and there's not much black around here, is there? There's just a little bit right there. This is probably oligohydramnios. Here on the right, you can see this nice black anechoic fluid and a good pocket of 4.28 centimeters. So that's normal fluid. The other thing, when I talked about Dopplers earlier, this is the umbilical cord Doppler, and it can show the blood flow through the baby to the placenta, and we're looking for restriction there. So here on the left, you can see a nice systolic flow and a nice diastolic flow. It's high diastolic. That means there's not much resistance. There's getting a lot of good blood flow. Here on this side, there's no diastolic flow, and there's actually reversal of flow. So this is a very high resistance flow, and this would be need to be alerted by the doctor immediately, because it could end up in fetal demise if they don't either deliver the baby or monitor it very close. So the first thing we're going to learn about in lab when we scan OB patients is a biophysical profile. And there's 5 biophysical parameters that are assessed individually and in combination. And when the baby scores really good, it means that the well-being of baby is good. So the ones we do with ultrasound are 2 through 5. And we want to look for fetal breathing movements. We want to look at the gross fetal body movements. So we want to see baby rolling around in there. Fetal tone means that we're looking for movement of the fingers and toes. And then we want to do an amniotic fluid index. The biophysical profile, the BPP, has a specified time limit of 30 minutes. So they have to pass, and the fetus has to pass and do everything within that time. And then we score them 2 points for each thing. Now, we don't mess around with scoring 1 point if they kind of did it. No, they either moved around or they didn't move around enough. So it's either 2 or 0. So what you want to consider normal for the biophysical profile part that we do in ultrasound is 8 out of 8. The non-stress test is performed at labor and delivery, at the birth care center, or a nurse performs that. So we don't do that part, but we do the 4 points: the breathing, the movement, the tone, and the amniotic fluid index. So this is where you're going to look at breathing movement, and I will just attach a YouTube video of the baby practicing breathing, just so you know what that looks like. It's hard to miss. They actually breathe quite a bit, and seeing the fetal breathing is such a good sign. You can also watch the breathing movement, not at the diaphragm, but at the kidneys. Sometimes the heart can kind of trick you up because it's also bumping, and it can look like breathing. So if you're having trouble, you can always move to the kidneys and watch them. I do like to watch breathing last for about 30 seconds, maybe 20 seconds. So they're just breathing for 20 seconds. I usually am like, I'm good with that. If I don't see breathing, I in 20 minutes, I get nervous. Even though they want to extend it to 30 minutes, I struggle with passing the baby because they should be really breathing within that time. Sometimes when they're in a deep sleep, it gets kind of difficult to wake them up, but within 20 minutes, they should have started breathing a little bit. The fetal central nervous system initiates and regulates the frequency of the fetal breathing movements. So the patterns may vary with sleep and wake cycles. So sometimes you have to try to wake them up by moving the mom, kind of jiggling the mom, have the mom drink some water, kind of sometimes perks them up. So this is kind of what we just went over. The fetal breathing movement, 1 episode for 30 seconds. If we see that, baby gets 2 points. If we see the baby move 3 times, it's 2 points. If we see active extension flexion of 1 episode of the limbs or trunk, it's 2 points. If we do the amniotic fluid index and there's at least a 2 centimeter and 2 perpendicular planes and a fluid measurement of 5 to 22, it's 2 points. Now, the interesting thing about this is you can have oligohydramnios and still pass your biophysical. So if you have 1 pocket of fluid in your amniotic fluid index, that's 4 centimeters, or 2 pockets that are 2 centimeters, and you can still say, yes, they pass their biophysical. However, they still have oligohydramnios. Now let's talk about the non-stress test, just so you know what that means. These are just images of the hand opening up. The non-stress test is done using Doppler to record fetal heart rate and reactivity to stress. Now, I know that you guys are kind of aware with how fetal monitoring is, where they put the Dopplers on the baby and strap them onto your belly, and then you can listen to the baby's heartbeat. It usually is around 30 minutes, and we want to see the acceleration of the heart. Now, we don't do this part, but it's good for you to know. Following the conditions indicate reactive or normal. So 2 fetal heart rate accelerations of 15 beats per minute, accelerations lasting at least 15 seconds, and gross fetal movements noted over 20 minutes without late decelerations. So this is a mom strapped in to get her non-stress test and the laying down, and then the strip is coming out here where they're going to watch baby's heart rate. Then a doctor reads this and says, okay, the baby's heart rate elevated, good. It didn't decel too fast. And then they pass it. Now the issue, so they don't, this is the thing, the non-stress test with a biophysical, if everything looks good, then we know the baby is doing well. Sometimes what happens is the baby will pass its biophysical, but not pass its non-stress test. And so the mom was getting a non-stress test and the baby didn't pass. So then the doctor will send them over to a biophysical to see if the baby passes that test. If the baby passes that test, they're good. They feel still good about it. The other thing that will happen, if sometimes we fail a baby because the baby is not like breathing or in too deep of sleep, then they will send them to the hospital to do a non-stress test. And if they pass that, then they're good. So they use both of these tests and together to really predict the baby's well-being. Okay, so Doppler measurements a little bit. We talked about this. When a baby is IUD, a lot of the times we'll do Doppler measurements. And the resistive index, maximum systolic velocity minus the diastolic velocity divided by the systolic velocity. Now, you don't have to worry about calculating any of this. The good old machine does this all for you. But a lot of the times we look at the resistive index is what we look at when we're doing the Doppler. So we'll do a measurement of the systole to the diastole, kind of like you do in your vascular stuff. And then it'll calculate your RI, resistive index, your pulsality index, kind of things like that. But we usually just look at if the baby has good diastolic flow, they're usually good. Now you can see here, there is no diastolic flow. This is not good. This is absent in diastolic velocity. This baby, you need to call the doctor on this baby. This is even worse. This is reversal of the flow. So this is, I feel like a pretty big emergency, and they need to be evaluated in the hospital when this happens. Now you can have a small baby or you can have a big baby. Macrosomia is classically defined as a birth weight of greater than 4,000 grams or greater in the 90th percentile. So these are the reasons you would have a big baby. If you've had multiple babies, greater than 35, pre-pregnancy rate of greater than 154, had a lot of weight gain, post-date pregnancy, I have a history of delivering LGA fetuses. It's really common in people that are poorly controlled maternal diabetics because the sugar levels are all messed up in the baby, and they can gain a lot of weight. In addition to adipose tissue, the liver, heart, and adrenal glands are increased in size, which can be reflected by an increased abdominal circumference. So these babies, although they're big, are not always healthy at all. They're actually sometimes as sick as the little ones because their sugars aren't regulated. So this is a large belly here. So you'll measure all the skin. This is a smaller belly. They have macrosomic fetuses have increased incidence of morbidity and mortality as a result of head and shoulder injuries and cord compression. So sometimes it's just better to do a C-section. There's 3 types of this. Fetuses are generally large, but especially large in the shoulders, or fetuses with normal trunk but large head. So you can have different things that are make the baby big. The first type can be because of genetic factors. The second type is found in diabetic pregnancies, and third type is genetic or pathological. The placentas can also get significantly large and thick um, because not immune to growth enhancing effects of the insulin. Placental thickness of greater than 5 centimeters is considered too thick. So remember that. And this is an image of a huge baby that's delivered. So this baby, although it's big, it does not equal healthy. So because of the insulin levels, sugar levels are going to be difficult to regulate. So this baby might be in the NICU with the little baby that is 1 pound and was delivered at 24 weeks. So it's not. We do want to watch this too on different things. All right. Have a good day.